Yes.
Mr. Anand?
सर कमलेश सर 1 मिनट में ज्वाइन कर रहे हैं।
Okay, okay. Anand, are you hearing me?
Yes sir, yes sir.
Yeah, I'm trying to share my screen. Just see it comes or not.
Yes sir, coming sir.
Is it visible?
Yes sir, it's visible sir.
Okay, okay. Anand, I think Dr. Kamlesh ji has joined, but
Yes sir, yes sir.
He's muted, I think. You have to unmute him.
सर आप म्यूट हैं सर, आप अनम्यूट कर लीजिए अपने आप को सर।
Good afternoon, sir.
Yes, sir. Good afternoon, sir. How are you?
I'm fine, sir. Fine.
I'm just sincere apology for not joining the last few classes because of some personal reason.
No, but Dr. Daria, Namit Das, they were
Yes.
carrying the responsibility.
Yes, my colleagues were very helpful and they continued I think the classes on time.
Yeah. It was going all right, sir. Now I am requested for questions, sir. You have to send 50 multiple choice question with answer.
Yes, sir. Beg your pardon.
Question for examination, sir.
Yes, yes. They are in the process, sir. They are in the process.
Yeah, yeah.
Yes. Now, today it's a happy news that the monsoon has arrived in Jaipur. It's raining now at present in Jaipur. Anand, Dr. Deria, I think, will not be able to join. He has joined, but is right now is taking a class of the final MBBS student. So probably he may not come on the screen right now.
Kamlesh sir, please proceed class, sir.
Yeah, yeah, we can start it now, sir. Doesn't matter. We can start now.
Okay, sir. Thank you. Anand, I think I share the screen. Is it visible?
Visual.
Yes, yes.
Okay, that's fine. My dear friends and the PG students, a very good afternoon to all of you. And it's the monsoon greetings from NIMS Medical College and Institute, Jaipur. Now, right now, it's raining quite a bit in Jaipur, and the weather is very, very pleasant right now. So, with the background of very raining season, I just want to start uh, a topic which is well known to many of us, but clinically it is still unrecognized in a clinical practice. And so today we'll be talking on antiphospholipid syndrome that a physician and PG student should know in his clinical practice. Now, what is this antiphospholipid syndrome? It is an autoimmune disorder. It is a multi-system disorder and a hypercoagulable state. It is an acquired disorder. And this syndrome which is characterized both by typical clinical and laboratory features. The clinical manifestations are in the form of vascular thrombosis or adverse pregnancy outcomes. And the laboratory features are the presence of antiphospholipid antibodies, which are mainly three, which are in clinical use: lupus anticoagulant, anticardiolipin antibodies, and the anti-beta-2 glycoprotein 1 antibodies. The important part of this definition of antiphospholipid syndrome is that these laboratory results should remain positive after 3 weeks, that after 12 weeks, that is 3 months, or up to 5 years. Now, in 1998, there was a classification, the so-called Sydney criteria for diagnosis of APS, and which was further updated in 2006. And that article came in the prestigious Journal of Thrombosis and Hemostasis. Now, this classification criteria for the diagnosis of APS, which came out in 2006. Slides are not moving.
Slide is not moving, sir.
Okay. Now, is it moving?
No, sir.
Mm. Okay. Anand, you want to take the Anand,
जी सर.
you want to take the remote control of my computer?
Yes sir. Yes sir.
Okay, I'll approve it. What happened? Anand? Anand, have you taken the control of my...
No sir. No sir.
Let me try this. I have given you the approval. I have given you the... now it's okay.
Sir, but not working sir.
Now, is it visible? Can you...
Slide is visual, like, but slide is
Yeah.
not.
Now, is it visible?
Sir, yes sir. Yes sir.
Okay. Is it moving now?
Yeah, yes, moving now.
Okay.
Okay.
So
Thank you.
I think I'll where I left the this was the in 1998 the first classification criteria for definition of APS was introduced, and it was further updated in 2006, and this consensus statement on the classification criteria for definite diagnosis of antiphospholipid syndrome was published in the very prestigious Journal of Thrombosis and Hemostasis. Now, this classification criteria for definite diagnosis is based on two parameters, the clinical criteria and the laboratory criteria. The clinical criteria essentially remains the same as the Sydney criteria of 1998. That is, the vascular thrombosis, one or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissue or organ. But this thrombosis must be confirmed either radiologically or histopathologically. Now, in addition, the two groups of antiphospholipid patients has been recognized in this classification. Either there is a presence or absence of additional risk factors for thrombosis. That is the so-called second hit hypothesis, which means that these patients who have antiphospholipid antibodies and they have other risk factors for thrombosis like presence of diabetes, infection, trauma, hypertension, and these are some of the risk factors for thrombosis. So, if there's a second hit hypothesis, means that the patient is at a higher risk for developing thrombosis. Now, the second clinical criteria for the diagnosis of antiphospholipid is the adverse pregnancy outcome, which can be either one or more premature birth of a morphologically normal neonate at or before 34th week of gestation, or one or more unexplained death of a morphologically normal fetus at or beyond the 10th week of gestation. Or it could be three or more unexplained successive, that is consecutive spontaneous abortions before the 10th week of gestation. And the rider is that one should exclude the chromosomal abnormalities, hormonal causes, and the maternal anatomic defects before labeling this attributable to antiphospholipid syndrome. Now, there were changes made in 2006 criteria, and these were mainly in the laboratory criteria. So the presence of anti-lupus should be present on two or more occasions at least 12 weeks apart, and the anti-cardiolipin antibodies of IgG or IgM isotype, they should be present in medium or high titer, that is more than 40 GPL or MPL, and should be positive at least 12 weeks apart, and they should be determined by the standardized ELISA method. So the main addition which came in this updated classification and criteria in 2006 was the introduction of another antibody, anti-beta-2 glycoprotein antibody, again of either IgG or IgM isotype, and its titer should be more than 99 percentile, that is more than 40 GPL or MPL, at least on 2 different occasions, 12 weeks apart. So this was the most updated classification for the diagnosis of definite APS. Now, with this classification, patients could be categorized into group 1 or group 2. Group 1 means they have more than one laboratory criteria, that is presence of either LA along with anticardiolipin or with anti-beta-2 glycoprotein, or these anticardiolipin or anti-beta-2 GP1 are present. Group 2 have been further subclassified into A, B, or C, depending on the presence of lupus anticoagulant, anticardiolipin antibodies, or anti-beta-2 glycoprotein 1 antibodies. So for the diagnosis of antiphospholipid syndrome, at least one clinical criteria, that is vascular thrombosis or adverse pregnancy outcome, along with one laboratory criteria must be present for the diagnosis. And this laboratory criteria should remain positive at least from 12 weeks to 5 years. Now, this diagnosis of the clinical criteria is relatively easy because it is in terms of the evidence of vascular thrombosis or pregnancy, adverse pregnancy outcome. But the laboratory criteria are more difficult because of the validity of the lab. So still at present, these 3 antibodies which are being used for diagnosis of antiphospholipid, the laboratory methods are not still standardized among the various laboratories across the globe, and therefore this has to be interpreted along with the clinical criteria. Now, the antiphospholipid syndrome is also known as Hughes syndrome, Alice syndrome, anticardiolipin syndrome, antiphospholipid syndrome, or antiphospholipid protein syndrome. These are various synonyms for this syndrome. Now, this APS has been classified into primary when there is no clinical evidence of another autoimmune disorder, or secondary when there is other cause like connective tissue disorder. The most common is SLE, or could be infections or drugs. Now, this is a whole list of APS which is secondary in nature, either because of systemic autoimmune disease associated with it, infections which could be viral, bacterial, or protozoal, and then malignancies which include solid tumors, hematologic malignancies, lymphoproliferative disease, and paraproteinemias. And of course, the non-malignant hematologic conditions, that is the benign hematologic conditions like ITP, sickle cell, and pernicious anemia. There are few class of drugs which can also cause antiphospholipid syndrome, and other miscellaneous conditions which are strongly associated with antiphospholipid syndrome include diabetes, autoimmune thyroid disease, inflammatory bowel disease, Klinefelter syndrome, and patients on maintenance hemodialysis. Now, what is the prevalence of antiphospholipid syndrome? In general population, it is only 1 to 4.5%. This is all Western data. And of course, but in patients who have lupus SLE, their prevalence is to the tune of 12 to 34%. In fact, more than 50% of patients with SLE may have these antiphospholipid antibodies, even if they do not meet the clinical criteria. This syndrome is more common in young to middle-aged adults, but can also be seen in elderly and children. There's a female predominance, especially in secondary APS, because the most common cause of secondary APS in clinical practice is lupus erythematosus, and there's no racial discrimination as far as the causes of etiology of primary APS is concerned. Now, there are various proposed hypotheses. I'll not go into details, but just give you an overview. There's activation of cellular elements, which include the endothelial cells, the monocytes, and the platelets. There is hemostatic reactions. There is what you call the activation of the coagulation system, inhibition of the fibrinolytic system. Then there is activation of the complement, and along with there is accelerated atherosclerosis because of the beta-2 glycoprotein 1 antibodies and the complex which it forms with the oxidized LDL. All these four components, they contribute to the genesis of antiphospholipid antibodies and the syndrome. Now, this cartoon just shows that how the antiphospholipid antibodies, they bind to the endothelial cells, platelets. There's a platelet aggregation and activation, along with activation of the endothelial cells and immune response, and liberation of pro-inflammatory cytokines. Along with this, if a patient has other risk factors for thrombosis, the so-called second hit, which could be trauma, infection, or non-immune pro-coagulant factors, they all contribute to formation of clot, and that is the vascular thrombosis leading to cause antiphospholipid syndrome. At the same time, there's deficiencies of protein C, antithrombin 3 deficiency. I have told you the fibrinolytic system is reduced, and there is increased activity of the tissue factor activity. All these culminate in vascular thrombosis in either which is arterial or venous, or even small vessel thrombosis. Now, coming to the clinical spectrum of antiphospholipid, it varies from no symptoms to catastrophic. So at one end, patient has positive antibodies, that is antiphospholipid antibodies, but there are no clinical manifestations. And on the extreme is the catastrophic, which is a life-threatening with high mortality rate. Now, thrombosis, I've told you already, it could be arterial or venous, and then you have the adverse pregnancy outcomes. And bleeding, of course, can be seen, but it's a very rare manifestation of APS. Now, it has been seen a large retrospective analysis in which patients without known autoimmune disease, the antiphospholipid antibodies were seen in 9% of patients with pregnancy losses, 14% with patients with stroke, 11% patients with myocardial infarction, and 10% with patients with deep vein thrombosis. The carry-home message is that these antibodies, that is antiphospholipid syndrome, should always be kept in mind when you're dealing with the pregnancy losses as enumerated before, or there is stroke or myocardial infarction in young patients. So it is very important that they have a high prevalence with these conditions also. Now, how do you clinically differentiate the primary APS with the secondary APS because of SLE? Now, patients who have secondary APS associated with lupus, they are more likely to have arthritis, livedo reticularis, heart valve disease, thrombocytopenia, leukopenia, and usually these manifestations are not seen in primary antiphospholipid syndrome. Now, coming to the clinical manifestations of antiphospholipids, the most is the vascular thrombosis, which venous is more common as compared to arterial, but we can also see small vessel disease also. Venous thrombosis usually occurs as deep vein thrombosis, can present as Burch-Charis syndrome, presenting as ascites, pulmonary thromboembolism leading to tachypnea and other manifestations, or they could be renal vein thrombosis, or patient can have renal vein thrombosis, retinal vein thrombosis. The lesser common arterial thrombosis, of course, they do occur. They usually affect the cerebrovascular system and can lead to the neurologic deficits, can lead to digital ulcers, gangrene of the distal extremities, myocardial infarctions, and you have the non-thrombotic endocarditis, that is the ligament sex endocarditis, or you can have retinal artery occlusions. So these are the various common manifestations of either venous or arterial thrombosis because of antiphospholipid syndrome. Now, patients with antiphospholipid who have experienced an episode of thrombotic, they have recurrence rate to the tune of nearly 5 to 12% every year. So that's very important because that determines how to follow up these patients and how to manage and prevent recurrence of thrombotic events. The important laboratory parameter, which is the main risk factor for recurrence, is either the presence of lupus anticoagulant or presence of all the three antibodies, that is the lupus anticoagulant, anticardiolipin, and anti-beta glycoprotein 1. Now just remember, usually a patient with antiphospholipid who have an arterial thrombosis, they usually if they have a recurrence, it would be an arterial event. And likewise, if a patient has experienced a venous thrombosis, then it is usually followed by a recurrence in the venous system. It is very uncommon that patient can have arterial thrombosis at one instant and the venous thrombosis at the other instance. Now, why there's a predilection for either venous or arterial circulation still, we do not know what is the pathogenetic mechanisms, but that is more of that patient presentation with arterial or venous thrombosis will behave uniformly throughout his life. Now, second clinical manifestation is the complications of pregnancy, so-called the adverse pregnancy outcomes, which I've already said, one or more unexplained death of morphologically normal fetus at or after 10th week of gestation, or one or more premature births of morphologically normal neonate before the 34th week of gestation, or three more or more unexplained successive spontaneous abortions before the 10th week of gestation. And the third, I already have told you, is that patients with APS with positive antibodies can be absolutely asymptomatic. As I've already told you, bleeding is a very, very rare phenomenon. Antiphospholipid syndrome is usually occur because of the platelet dysfunctions, both quantitative as well as qualitative, and there could be presence of factor VIII inhibitors, so-called the acquired hemophilia. And the fifth important manifestation, which has high mortality rate to the tune of more than 50%, is the catastrophic antiphospholipid syndrome. The prevalence is less than 1%, and they usually present with multi-organ venous arterial thrombosis, and which affects the kidneys, lungs, the central nervous system, heart, and skin. It has a very rapid onset with high mortality, and in nearly 1/4 of the cases, it is complicated by DIC. Now, how do you diagnose catastrophic APS? By the so-called criteria which has been given by the updated criteria, there is the clinical evidence of vessel occlusion affecting 3 or more organs or systems, and these manifestations usually should develop either simultaneously or within 1 week of onset of symptoms, and it should be confirmed that the small vessel occlusion should be confirmed in at least one organ by histopathology, and there should be a serological presence of antiphospholipid antibodies, the lupus anticoagulant or the anticardiolipin. So the definite catastrophic APS, when you have all the 4 criteria are met, probable means either there's a presence of 1, 2, or 4, or 1, 3, or 4, provided that these clinical manifestations of catastrophic, they develop within a period of 1 month. If they meet these are the probable, that is the catastrophic APS. Now, coming to again, the antiphospholipid syndrome, the gender predilection, I've told you that females are more prone because secondary APS, and usually which is associated with lupus, is more commonly seen in females, and they usually have arthritis, libido reticularis, and migraine. And males often have usually present with coronary artery disease, epilepsy, or they have arterial thrombosis in the lower extremities. Now, coming to the system-wide involvement in antiphospholipid syndrome, the neurological involvement is seen is a common feature of APS, and it is because of vascular thrombosis as well as because of direct injury to the neuronal tissue by the antiphospholipid antibodies. Stroke and transient ischemic attack are the most common neurologic manifestations. And just remember that a thrombotic stroke occurring in a young patient with no overt risk factors for cerebrovascular disease is a classic setting in which one has to suspect APS. There are other, of course, red and yellow flags, which I'll enumerate later in my course of my lecture, that when we should suspect APS in your clinical practice. Then the other neurological involvement could be the cognitive deficits and the white matter lesions. And these cognitive dysfunctions are usually associated with presence of libido reticularis or white matter lesions on brain MRI. Less common neurologic disorders include the epilepsy, psychosis, various movement disorders like chorea, hemiplegismus. They can have transverse myelopathy or sensory neural hearing, orthostatic hypotension, that is a part of the autonomic system the derangement, or even migraine. These are the less common neurologic diseases, which of course can be seen in antiphospholipid syndrome. Coming to the second important organ system is the hematologic abnormalities. Thrombocytopenia is commonly seen in nearly 20 to 42% of patients. So in the usual workup of unexplained thrombocytopenia, so the evaluation of lupus anticoagulant is one of the basic laboratory feature. Now, this thrombocytopenia is more common seen in secondary APS, which is usually associated with lupus. This thrombocytopenia is usually moderate and rarely it is associated with hemorrhagic events. Now, even if a patient has thrombocytopenia, it does not preclude the occurrence of thrombotic complications. Now, other various hematologic abnormalities which have been reported in patients with antiphospholipid syndrome include the autoimmune hemolytic anemia, bone marrow necrosis, especially if there is widespread thrombosis, and the thrombotic microangiopathic syndrome, that is TTP and HUS. Now, pulmonary involvement is also commonly seen in APS as a thromboembolic disease. And it can also present as a non-thromboembolic hypertension, that is, arterial hypertension is there. Patients can have pulmonary microthrombosis, can present as ARDS, or can present with diffuse alveolar hemorrhage. Now, cardiac involvement usually occurs in forms of valvular thickening, presence of nodules on the valve, that is the so-called non-bacterial vegetations, and usually the mitral and aortic valves tend to be affected, which leads to regurgitation. Stenosis is very less commonly seen, and these aortic nodules which are present are highly associated with high risk of stroke. And the risk of heart valve disease is much higher in patients who are positive for lupus anticoagulant, or they have anticardiolipin isotype IgG. Myocardial infarction can occur because of coronary thromboembolisms, accelerated atherosclerosis. The cutaneous manifestation, the most common, what you have already said, is the livedo reticularis, and is commonly associated with arterial lesions, multiple thrombosis, and is commonly seen in females who have secondary APS. Other cutaneous manifestations include the splinter hemorrhages, cutaneous necrosis, infarction, superficial vein thrombosis, digital gangrene, skin ulcerations, and then you have the lesions which simulate vasculitis, so-called the pseudovasculitic nodules and macules. Another important organ system which can be affected is the renal kidneys, and these, of course, are less commonly affected in patients with primary APS. Usually, glomerular capillaries and vessels are affected, and this disease can be either silent or can produce acute or chronic renal failure with proteinuria. So in patients who have unexplained acute or chronic renal failure with high proteinuria, one should also think of antiphospholipid syndrome. No, I have already told you it is a multi-system disorder that affects from head to toe. So GI is also involved in antiphospholipid syndrome. It can cause ischemia of the esophagus, stomach, duodenum, jejunum, and the whole colon. Can result in GI bleed, could be abdominal pain, could be there, perforation, or there could be gastric or typical duodenal ulcerations. Infarctions can occur in the pancreas and spleen. One can have hepatic or portal venous thrombosis, which is resulting in Burchard syndrome. You can have veno-occlusive disease of the liver. You can have infarctions or portal hypertension and cirrhosis. So these are the varied manifestations, GI manifestations of antiphospholipid syndrome. As I've already said, the eyes are also involved. It could lead to the retinal venous or the arterial thrombosis. It can lead to the ischemic optic neuropathy. Adrenals, of course, are rarely affected, but they can be seen because of the bilateral renal vein thrombosis resulting in hemorrhagic infarction. and they usually present as severe abdominal lumbar or pelvic pain. And this has been reported adrenal involvement to the tune of 13% in patients who present with catastrophic APS. So adrenal involvement is more commonly in clinical practice in patients who develop catastrophic APS. Now, osteonecrosis, again, there's a strong association between osteonecrosis and APS, though the patients may be asymptomatic and they're usually detected on MRI. And but in a study which has been seen that the 30 patients who were the subject of one study, none had changes on plain radiographs and none had progressive changes on subsequent MRIs. So the real association and relevance between osteonecrosis and APS is still not clear. Now, coming to why, when, and in whom we should suspect the occurrence of antiphospholipid syndrome. The red flags include the unexplained DVT or pulmonary thromboembolism in young patients less than 50 years of age, stroke or TIA in again less young adults, or there's a recurrent thrombosis or thrombosis at unusual site, unexplained fetal loss after 10-week gestation, or patient has severe or early preeclampsia with IUGR or with severe thrombocytopenia, or patients have had heart wall disease, or a patient who is newly detected lupus and one should always suspect APS as one of the association or the cause of the clinical manifestation. The yellow flags include the presence of livedo reticularis, the Raynaud's phenomena, unexplained persistent thrombocytopenia, recurrent early pregnancy loss, or unexplained adrenal insufficiency, which is usually seen in catastrophic APS. So this is a pictorial representation of the various manifestations of APS, include the CNS, that is migraine, stroke or TIA, pulmonary thromboembolism, the cardiac valves and coronary artery disease. You can have renal vein thrombosis, infarction, and if nephropathy could be there. Then you can the pregnancy, adverse pregnancy outcomes, including the preeclampsia, IUGR, Raynaud's phenomena, the typical livedo reticularis, and deep vein thrombosis. So whenever you have these manifestations which cannot remain unexplained, especially in young patients who have stroke or myocardial infarction or pulmonary thromboembolism, one should think of antiphospholipid syndrome. This is the fundoscopy of the retinal artery thrombosis. One can see the pulmonary thromboembolism clot is there, the pulmonary artery, pulmonary hypertension is there. And these are the non-bacterial vegetations on the valve, the dilated cardiomyopathy. Then there's accelerated, I have told you, the accelerated atherosclerosis occurs because of the complex between the beta-2 glycoprotein antibodies and the oxidized LD form, which leads to accelerated atherosclerosis. And these patients can have, so a patient with APS either can have normal coronaries with coronary microthrombosis causing MI, or can have atherosclerotic disease causing myocardial infarction. This is the typical appearance of livedo reticularis. It is seen in nearly 40% of patients with secondary APS. And what you can see, the cyanotic discoloration at the junction of the territories of adjacent artery roads. Deep vein thrombosis, which is very common, especially in patients who have higher risk factors or have second hit risk factors. I've already discussed the complications of pregnancies related to the either one of these three complications of pregnancies. Now, what is the pathogenesis of these obstetric complications of antiphospholipids? Now, it is a thrombophilic state, and therefore there's a thrombosis of placental vessels, which results in placental infarction. Then the antibodies to annexin 5. Now they form annexin 5 forms an anticoagulant shield on the phospholipid surface of trophoblast, and these antibodies the beta-2 glycoprotein 1 with the beta-2 glycoprotein complex, they disrupt this shield, and therefore that leads to the obstetric complication. Of course, the exaggerated protein complement activation also on the trophoblast leads to state of inflammation and thrombosis. Now, besides the thrombotic mechanisms there of early fetal loss, there could be a direct effect on the placental thromboplast, inhibiting the expression of human chorionic gonadotropin. There could be trophoblast apoptosis. There could be decreased trophoblast fusions, and all limiting the trophoblast invasiveness and function. Now, coming to another entity of phospholipid is the microangiopathic antiphospholipid syndrome, when it involves the small vessels presenting as TTP, or can present as HELP syndrome, or the catastrophic APS. So the microangiopathic antiphospholipid syndrome can present as TTP or HUS, HELP syndrome, or the catastrophic antiphospholipid syndrome. Bleeding is another rare complication of APS, and I have told you it is because of the platelet dysfunction, both qualitative as well as quantitative, and presence of the acquired inhibitors to factor VIII, that is the so-called acquired hemophilia. Hemolysis, again, autoimmune hemolysis is a feature of APS and is more common in secondary APS, which is usually associated with lupus. Now, coming to the laboratory diagnosis of APS. Now, it's very important to understand, because the presence of simple the report you get from the laboratories which say that the lupus anticoagulant is, or the anticardiolipin, or the beta-2 glycoprotein is positive, does not really mean that the patient has APS. Now, one should be very aware that the values which are given by the laboratories, they match with the kit which they are using, and they do not match the criteria many times, and therefore simply the presence of these antibodies, if there is no clinical manifestation, one should be very cautious in making a diagnosis of antiphospholipid syndrome. Now, among the laboratory criteria, lupus anticoagulant is most important. Now, this test is usually performed because these tests are all dependent on phospholipids, and therefore has to be done with platelet poor plasma. And since there's the presence of antibodies, that the patient's serum is not corrected with the normal plasma, which usually occurs when there's a presence of any deficiency of any factor. So since there's a presence of inhibitor, that is the antibody, therefore these tests, they do not correct when you mix the patient's serum with the normal plasma. And these tests, the various antiphospholipid antibodies, the test can be corrected with use of excess phospholipids. Now remember, I've told you that anticardiolipid antibodies should be present to the tune of more than 39%, that is 40 GPL or MPL of either iso G and iso M isotype. But many of the laboratories even have a titer of only 12 or 15 GPL or MPL. They give the report of positivity, which of course is incorrect. So remember, the interpretation of the laboratory test should be made along with the clinical manifestation, and one should always ask the titers of these antibodies. Simply the positivity or negativity do not convey that the patient has antiphospholipid syndromes. And these laboratory abnormalities should persist for 2 or more occasions, at least 12 weeks apart, up to 5 years. So coming to the criteria for diagnosis, the lupus anticoagulant. Now we have the guidelines from the ISTH, which was given in 1995, that since it is presence of the inhibitor, therefore it is a failure to correct the prolonged coagulation time with the normal plasma of the patient, and this clotting time, that is which is prolonged, is corrected by use of excessive phospholipids. And of course, one has to rule out other coagulopathies, especially the inhibitors to factor VIII. Now, lupus anticoagulants is not homogeneous. It is basically a heterogeneous class of antibodies which are directed against beta-2 glycoprotein and prothrombin, and they have the property of prolonging the clotting times of phospholipid-dependent clotting. The most common which we use is the activated partial thromboplastin time, APTT. Now, this detection assay is based on this functional property. And of course, it has strongest association with the thrombotic events. One has to correlate with the presence or absence of the vascular thrombotic event. Now, this lupus anticoagulant is a misnomer because it does not cause bleeding, it causes thrombosis. Therefore, it is a misnomer because of its association initially with lupus anticoagulant. Now, when you screen for lupus anticoagulant, it should be done on two different test systems. The most common one which we use in clinical practice is the evaluation of the intrinsic pathway, that is the activated partial thromboplastin time, which is not corrected with normal PASA or which is corrected by the excess of phospholipids. And the most sensitive one is which assesses the common pathway, that is the dilute Russell Viper venom time. Then the other test is the clotting time, again, which assesses the intrinsic pathway. And then you have the dilute prothrombin time and a dilute APT. So these are the various screening tests for lupus anticoagulant. Remember, one should always use platelet poor plasma because platelet can release phospholipid and give you a false normal report. Now, I have told you in clinical practice, the most common test for evaluation of a lupus anticoagulant is what we see, the prolongation of APTT. Now, this I've told you the presence of an inhibitor not corrected by the normal plasma, but corrected by excess phospholipids. But remember, a normal APTT does not rule out presence of lupus, as the various reagents available for performing this test, they vary in sensitivity to lupus. And therefore, the different manufacturers and kits which are used by the laboratories are not uniform across the globe. And though many times when you have a strong suspicion of antiphospholipid syndrome, but your lupus anticoagulant, which is done by APTT, can be a normal. So it is very important to know that because of the reagents and the method and the manufacturing kit which the laboratory uses to assess, it is very important to know the sensitivity in performing this test. Therefore, I've told you that the clinical criteria is much more straightforward as compared to the laboratory parameter. They have to be interpreted very intricately with the clinical manifestations. Now, this is the most sensitive test to assess the lupus anticoagulant DRVVT, and it acts directly on factor 10. And like this prolongation of DRVVT is not corrected by addition of normal plasma, like in the APT, of course. So these have the common features, but it is very sensitive to pick up the presence of lupus anticoagulant. I've already told you about the DVRT, which assesses the common pathway, APTT and coagulant assesses the intrinsic pathway, and then you have the dilute prothrombin time, which assesses the extrinsic pathway. So these are the various screening tests for the presence of lupus anticoagulant. Now, if a patient the laboratory gives a positive lupus anticoagulant, then the question comes, should we test for other two antibodies, that is anticardiolipin as well as the beta-2 glycoprotein? The answer is yes. The reason is because the presence of one or two or all three antibodies, they quantify the risk of thrombosis. Now, I've already told you the presence of lupus anticoagulant denotes the highest risk for thrombosis. Then triple positivity, again, very high risk. And if you have antiphospholipid antibodies in a patient who has lupus, again, there's a higher risk of thrombosis. And of course, one should always evaluate other risk factors, so-called the second hit hypothesis. Remember, it is not an all or none phenomena. So it's very important that not only lupus anticoagulant, other two antibodies should also be evaluated in a patient who has suspected APS. Now, anticardiolipin antibodies, a few words about them. Again, is a misnomer because the target is not the cardiolipin. It is usually detected by ELISA. And just remember the cardiolipin-coated plates which detect other antibodies also against the phospholipid binding proteins. and therefore the interpretation of these anticardiolipin antibodies, the results vary from one lab to other, and depending upon what type of kits they are used and what is the sensitivity of these kits to the presence of phospholipids. Now, what are the problems in detection of anticardiolipin antibodies? Various systems have been used, various commercial kits are available, and therefore, there's no internationally accepted reference material. Just like we are doing prothrombin time, INR, we do not have an internationally accepted reference material as far as detection of anticardiolipin antibodies are there. Now, I have told you that the normal values which are used by in commercial units, kits are usually less than 10 or less than 7. But just remember, but not all positive results are considered clinically relevant, because what we are using in the criteria which has been laid down in 2006 is which is clinically relevant is more than titers of 40 GPL or MPL or more than 99 percentile. And that positivity should remain even after 12 weeks or 3 months. So whenever you have a clinical suspicion of antiphospholipid, one should go for, the commonest is the detection of lupus anticoagulant by APTT. If it is prolonged, one should the mixing study should be done. And if it suggests that there's the presence of lupus anticoagulant inhibitors is present, if all the other two antibodies should be done for the diagnosis of antiphospholipid syndrome. So the laboratory diagnosis, to summarize, one should perform lupus screening by at least 2 methods. That is, one is APTT, other is the dilute Russell Viper venom time, and confirm. One should perform anticardiolipin by ELISA test, both IgG and IgM isotype. One should perform anti-beta-2 glycoprotein antibodies, again IgG and IgM type. Again, we should perform the titers, that is quantitative titers. And if they are still positive to 12 weeks, then only we can say that this patient has a positive laboratory features of antiphospholipid syndrome. Now, timing of testing is very, very important. What happens, usually we do whenever a patient has a clinical event, that is a thrombotic event, the initial testing is usually done immediately, and of course we repeat after 12 weeks. But just remember, the presence of large thrombosis or use of an anticoagulant can falsely normalize the result for EPTT. Therefore, when you have an acute event for detection of the lupus anticoagulant, then instead of going for EPTT, I think one should always go for the 2 antibodies which are done by ELISA, that is anticardiolipin and the beta-2 glycoprotein, because they are not affected by the acute thrombotic event. They are not affected by the anticoagulation. So a normal EPTT in acute setting, remember, may be inaccurate and may not reflect that the true picture or clinical picture of the patient. So interpretation of the positive result, not every positive test is clinically significant. Interpretation of clinically significant antiphospholipid positivity should take into account the type, isotype, the titers are important, persistency beyond 12 weeks, and the number of positive APL tests, 1, 2, or 3, is very important. This is very important if you are suspecting a patient of APS. Now, clinically significant titers at the presence of 1 or more of the following on 2 more occasions should be there. But in many times, if you have a titer, you do not have low titers of less than 40. But in certain cases, one can also use the IgA isotype. But of course, the guidelines say that one should restrict to the isotypes M or IgM with titers more than 40, either with anticardiolipin or with anti-beta-2 glycoproteins. Then many times you have a titers between which is intermediate 20 to 39. Of course, that has to be interpreted with clinical results. And many times these antibodies, they are present in others, that is the so-called what we call transient or APLA, which occurs most commonly because of viral infections. Then patients we have can have individuals can have antiphospholipid antibodies, but they are asymptomatic. This is what we call as transient antiphospholipid syndrome, and these patients have transient antibodies, but they do not have clinical features. The clinical significance is not there. One has to simply follow these patients with antibodies, and we're not clear that how should we follow these patients and how to manage these patients when they have persistence of antibodies but no clinical manifestations. But in some individuals who have risk factors for thrombosis, that is the second hit hypothesis, one should correlate even with the intermediate levels of antiphospholipid antibodies in the assessment for risk for thrombosis, and then primary prophylaxis can be given. Then again, individuals who can have medium and high titers antiphospholipid syndromes, they can have persistent medium high titer, that is more than 40. And the two common conditions which we see is the patients with SLE and patients undergoing coagulation screen. Very often when patients come for pre-surgical evaluation and you order for APT and APT, what you find is APT is prolonged and the anesthesia refuses, the surgeon refuses to take up the patient for the elective surgery. One should interpret APT because of the presence of inhibitors. Now, how to manage these patients of antiphospholipid? So coming to the primary thrombosis prevention, one has to assess the risk of thrombosis. So primary thrombosis prevention is based on the increased risk of thrombosis with the presence of antiphospholipid antibodies. And the annual risk of thrombosis among individuals who have antiphospholipid antibodies in the setting of SLE is likely to be less than 4%. And the risk in individuals without SLE is less than 1%. Therefore, to decide upon the primary antithrombotic prevention, thrombotic prevention, or anticoagulation for prevention and prophylaxis, one should take account the presence of SLE or with or without SLE, because with SLE the annual thrombosis risk is less than 4%, but is nearly 1/4 without SLE. Now, so what is the role? Is there the role for primary prophylaxis in patients who have without no clinical criteria? So use of antithrombotic medication, aspirin or anticoagulants is not advocated for primary thrombosis prevention in patients who have antibodies with or without SLE, who do not have APS, unless it is appropriate that they have some other risk factor, that is so-called second hit hypothesis, that is they have other risk factors for cardiovascular risk reduction. So if a patient has diabetes, hypertension, has dyslipidemia, has morbid obesity, is a smoker, and does not have thrombosis but has positivity of significant titers of antiphospholipid, he can be put on prophylaxis. Otherwise, it is not, aspirin or anticoagulant is not advocated. Now, in obstetric practice, what is the role for primary prophylaxis? Now, the use of aspirin or anticoagulant to prevent first thrombosis in patients diagnosed with APS based on the prior pregnancy morbidity is not advised unless it is recommended for other reasons like the cardiovascular risk reduction. So a patient has a prior pregnancy morbidity, but if you want that in subsequent pregnancy you want to prevent, aspirin or anticoagulant is not advised. Now, this advice is usually based on lack of evidence that the aspirin or the anticoagulant, that is heparin, will have a protective effect as far as the primary thrombosis prevention is concerned in women who have history of obstetric APS. Now, acute thrombosis, that is the management is like with all the other thrombotic events, heparin along with oral anticoagulants. You start heparin along with the oral anticoagulant. It is usually the vitamin K antagonist. As of now, standard of care, though Novex, that is the non-vitamin K antagonists, are not used in antiphospholipid syndrome. So you start along with heparin, and once the INR reaches between 2 and 3, you stop heparin, and once a patient has a thrombotic event, is diagnosed as APS, then the therapy is given indefinitely because of the high rate of recurrent thrombosis. And though there are little studies to quantify the risk, but it's very important that these patients should receive thrombotic treatment lifelong. Now, as I've already told you, anticoagulation with warfarin is preferred over the newer oral anticoagulants because of the lack of data which is regarding the efficacy and safety of the newer anticoagulants in antiphospholipid syndrome. So as of now, this is the standard of care, though various trials are undergoing where they are using various oral anticoagulants like apixaban, dabigatran, rivaroxaban in patients with APS. Now, coming to the secondary thrombosis prevention, now the long-term anticoagulation is the mainstay of therapy. Now, treat venous and arterial thrombosis in men and non-pregnant with APS in the same way as with standard intensity warfarin, and patients with arterial thrombosis, you can add aspirin to the warfarin. Those who have additional cardiovascular risk factors or they have multiple thrombotic events even on the therapeutic dosage of warfarin. Now, a question always is asked by the patient with antiphospholipid, can I stop anticoagulation? For most individuals with antiphospholipid and history of unprovoked thrombosis, lifelong anticoagulation because of high likelihood of recurrence and potentially devastating nature of recurrent. So the lifelong anticoagulation should be there, and you can select in selected APS patients, you can stop anticoagulation if there is evidence of provoked thrombosis, especially when the patient who has undergone hip surgery or knee joint surgery, who is bedridden, provided the titers of the antiphospholipid antibodies are low. So if the low antibody titers are low and there is a clear evidence of provoked thrombosis, then one can take a decision after explaining to the patient that anticoagulation can be stopped, but there is risk of recurrence of thrombosis. And remember that once you have a patient, you continue to follow these antibodies. These antibodies are usually followed up in titers only when you have a consideration to stop anticoagulation. Otherwise, one should never do routine, what you call the annual determination of these antibodies who have confirmed antiphospholipid syndrome and who are on lifelong anticoagulation. So now, at times when you have adequate anticoagulation, but there's a recurrence of the thrombotic events, and one should always assess the other risk factors and should address these factors. And then if you are using the oral vitamin K antagonist, one can increase the titer to supratherapeutic range, that is 3 to 4. Or if you feel, then one can add either warfarin to low molecular weight heparin or aspirin, but the risk of bleeding, of course, becomes higher when you're using a dual therapy. Sometimes one can use also hydroxychloroquine or statins, but there is no data, clear-cut data, which says that their use is superior to other approaches. Therefore, as of now, they are much inferior as compared to warfarin or aspirin combination or with heparin combination. Now, always there's a challenge in patients with APS in monitoring the INR, because prolongation of the baseline may even occur in patients 5 to 10% because of lupus anticoagulant effect. So before you start acetone, you do a baseline PT, and at times what happens in 5 to 10%, these patients already have a prolonged prothrombin time. But if you are using the thromboplastin times, now usually we have a thromboplastin times which are standardized and which have uniform standardization all over the globe. They are less sensitive to lupus anticoagulants, and therefore if you use high concentration of phospholipids, then the PT assay would be more accurate. Of course, one has to act in concert with the pathologist and the laboratory that what happens because routinely they take these patients, you have to provide clinical data to the laboratory personnel and the pathologist that this patient has baseline high PT-INA because of APS, because of lupus anticoagulant, and therefore they should perform this test with a more sensitive thromboplastin, and they should have a higher concentration of phospholipids in the reagents that would give more accurate picture of prothrombin time. Now, to assess the safety of anticoagulation, now patients usually have thrombocytopenia, I have told you, but they usually have what are called moderate thrombocytopenia, and one has to balance the potential risk with the benefits. And anticoagulation, you can continue if the platelets are more than 50,000, as long as there is no clinically significant active bleeding and the platelet count is stable. There have been the role of immunomodulatory agents. I have told you about hydroxychloroquine and statins, and rituximab, of course, have come into picture in patients who have hematologic manifestations, that is the ITP with autoimmune hemolytic anemia or ITP, or they have thrombotic microangiopathy. The role of D-dimers in HEPLA is, of course, it just shows that there's an active thrombotic process, and patients who with secondary APS who have positivity for lupus erythematosus, that is, have lupus, they have increased rates of thrombosis, especially the dimers are more than 2 microgram per ml. For the management of stroke, which is associated with APS, they have compared the high dose of aspirin with intermediate warfarin, and they have found that both are, they did not find any non-inferiority with either of them, and especially in females who have IPS and stroke, dual combination of aspirin with dipyridamole is much more superior to aspirin, and clopidogrel alone is of course more superior to aspirin in treatment of patients of young stroke with APS. And aspirin is as effective as warfarin in preventing the recurrent events, and long term, of course, there are less recurrence. Aspirin, of course, depending upon the risk GI tolerability of aspirin, one can use either aspirin or the oral anticoagulant. And one, if the patient has atrial fibrillation, of course, the oral anticoagulant would be the drug of choice. For the APS with the coronary artery disease, of course, the statins and hydrochloroquine, and the of course the aspirin, and especially the warfarin, one can use for pulmonary thromboembolism on long-term basis. And for the treatment of catastrophic, it requires anticoagulation, steroids, plasmapheresis, and IVIG. It is an acute medical emergencies, and patients with lupus flare-up should be rescued with cyclophosphamide, and of course other agents which have been used are cyclosporine, splenectomy, and fibrinolytic agents. But the only drug which appears to have any effect on the mortality in catastrophic APS is the anticoagulation. So to summarize, what a recommended treatment for antiphospholipid. So asymptomatic APL positive patients, no treatment. Venous thrombosis, warfarin, with keep in a therapeutic range. Arterial thrombosis, if you have recurrent, either use warfarin in supratherapeutic dosage to keep INR between 3 and 4, or you add a low dose aspirin. And of course, if patient with catastrophic APS, you have to use corticosteroids, IVIG, or plasmapheresis, along with anticoagulation, as these are the life-saving measures. So and regarding the treatment in pregnancy, adverse effects in pregnant women with asymptomatic APL positive, no treatment. Single pregnancy loss, no treatment. If you have recurrent embryonic loss or fetal loss and no history of vascular thrombosis, you give low dose aspirin with prophylactic heparin during pregnancy, heparin in the postpartum period, and then the low dose aspirin thereafter. If a patient has recurrent embryonic loss and history of vascular thrombosis, you give therapeutic dose of heparin along with low dose heparin during pregnancy, warfarin, and postpartum. And if a history of vascular thrombosis, usually you give a low dose aspirin along with therapeutic dose heparin during pregnancy. Then you continue anticoagulation in the postpartum with warfarin. To summarize, it is an autoimmune disorder, presents multi-system disorders, affects the vital organs of the body, can be asymptomatic or can lead to a catastrophic APS, and usually there's the presence of antiphospholipid antibodies, usually associated with thrombosis or pregnancy, morbidity. And then one should always screen for all the three antiphospholipid antibodies because they determine the risk for thrombosis. And just remember, one should not do a random testing in unselected patients. And one should always, if you suspect, one should always perform all the three tests. Thank you very much. I think most of you must be in this state of, especially after lunch and in this pleasant weather when it is raining in Jaipur. Thank you very much.
Thank you so much, sir, for your enlightening talk on APS that every physician should know about the antiphospholipid syndrome. It was very lucid presentation, sir. So, on there is no question in chat box today. No, no, yes.
There are too many. Dr. Taullah Khan, very nice to see you back. Yes, I also missed the last few lectures because of some personal reason. And in fact, still I'm like have some commitment, family commitment. So only last evening, Dr. Denua reminded me that tomorrow, sir, you have a lecture. So luckily I had my slides ready and I just came from the hospital and started my lecture. Thanks to see you all back. And of course, Daria, you have finished your class. Then
Thank
any
you so much, sir,
questions?
for your just because of your family commitments, still you come for the lecture, and everybody is happy now seeing you here after a long time. And really, it was a very good lecture. So there are some questions posted above with image.
D-dimer FDPs are normal in caps or elevated. So whenever there's a thrombotic event, just remember D-dimers and FDPs are elevated. Even if you do these tests in a post-surgical patient, now these will be tested. So one should interpret the presence of D-dimer with presence of any clot and clot. This could be a surgical clot, could be a spontaneous clot in the artery or in the vein. So these are always elevated in the presence of some clot because if the fibrinolytic system, when it acts, it produces the breakdown of the clot as D-dimer and you have the fibrin degradation products are there. Is there any condition causing false positive lac LAC, anti-glycoprotein? Yes. No, certain viral, the so-called transient APS, they have low titers of antiphospholipid antibodies, especially falling viral, and you have atypical organisms like mycoplasma. But these antibodies do not persist beyond 12 weeks as it is required as per the definite criteria for definite diagnosis of APS. So you can have low titers of antiphospholipid antibodies following a viral infection, and usually they do not manifest with thrombotic event. They are clinically silent. So we call it as silent APS also. When we
Thank you, sir.
order APLA profiles, labs are giving antiphospholipid antibody, IG, IgM, IG. Yes, these are the as per the criteria, that is the updated criteria 2006. It is the isotypes IgG and IgM.
Another question is, sir, in pregnancy, give only LMWH or along with aspirin?
In which state? Aspirin in which condition of APS?
The aspirin, you want a particular or it's an only APS in pregnancy on with the LMWH and aspirin?
In pregnancy?
Yes, sir, in pregnancy.
Yes, I've told you it depends upon what is the vascular event is not the one episode has occurred or not. So if you feel that the patient has a previous bad obstetric history attributable to APS and patient has one history of vascular thrombosis, then one can use low dose aspirin along with heparin during pregnancy. In postpartum, one can use the vitamin K antagonist.
Another question is there that somebody already receiving the steroids, then will the titers of antibodies will be lower or not?
No, the steroids have no effect on the titers of the antibody. Yes. So, because just remember, you are not treating APS with steroids. If APS were been treated with steroids, it is very obvious to think that they would reduce the titers. No, steroids are absolutely not indicated in treatment of APS.
Somebody asking about the interpretation of images of report. Actually, I was not doing it earlier. Mr. Satija is asking about the images, report image, how to interpret.
Can you please repeat, Daria? You're not audible.
Interpretation of images of report, how to interpret the image of these reports.
Acha, those reports, of course, they are not clear. Those, either you do a screening, share the screen as AP. Can you, who is the Satija?
Yes,
Satija.
Mr. Satija.
Can you come on the mic?
Yes, sir. Can you hear me, sir?
Yes.
Yes, sir. In the reports they have given, sir, I have sent a patient who is having a patient is having DVT 2 years back, sir.
Okay. Was it provoked or unprovoked DVT?
It was unprovoked, sir. 2 years
Okay.
later, he is having a TIS, sir.
Yes.
Now he is having ischemic stroke, sir, with aphasia, sir.
Okay.
We have sent, so patient is having autoimmune hemolytic anemia, sir, like
Okay.
direct and indirect Coombs test positive, sir.
Okay.
And thrombocytopenia is present, sir.
Okay. Patient is a male or female?
Female, sir, 40-year-old female, sir.
And what about lupus?
Yes, sir. There is
Then
no
this-
clinical.
Probably
No
this
clinical.
patient, this probably has secondary APS. This lady has secondary APS associated with APS. Yeah. So what is the report says? Because I can't read unless you have a
Yes, sir.
slide and repeat.
I can tell you the report, sir.
Yes.
One second, sir. In this report, first ANA profile we have done, sir.
Yeah.
In ANA profile, there is Rho antibodies are positive, sir.
Okay. This is about the connective tissue immuno profile you are telling me.
Yes, sir. Yes, sir. And
No,
then
I just want to know about the anti-phospholipid antibodies.
Yes, sir. In antiphospholipid antibody, first cardiolipin antibodies we have sent, sir.
Yes.
IgG cardiolipin antibody titer is 6, sir. 6.80, sir.
So 6.80 is normal.
Yes, sir.
What is the
And
reference value?
IgM is 21.9, sir.
Again, it is intermediate, not because as per the criteria for definite diagnosis of APS, it should be more than 50.
Sir.
Yeah.
Yes, sir. And antiphospholipid IgM antibody is 0.3, sir. They have given like antiphospholipid IgM antibody, sir.
Yes.
They have not specifically mentioned about lupus anticoagulant, sir. Will we consider this as lupus anticoagulant, sir? Antiphospholipid
Yes,
IgM
this
antibody?
is there because they have done against the antiphospholipid in general. It is a heterogeneous test. So
Okay.
some
We will consider this test as lupus
this
anticoagulant.
is also
sir.
negative. Yes.
Yes, sir. And antiphospholipid IgG titer is 0.23, sir.
So it is negative. It is not a case of APS. I think a young female with lupus must be lupus because she has AIHA, she has thrombocytopenia, she has this. I think of some other cause. APS is unlikely.
Okay. APS is less likely, sir.
Yeah, because they are negative. You have to have one clinical manifestation, and you have to have one clinical laboratory parameter which should be positive, should be in clinically significant titer, and which should remain persistently positive at least for 12 weeks, that is 3 months. So that is the criteria. But these are the guidelines actually. When you strongly suspect, one should depend upon the. So why don't you go for the beta 2 glycoprotein antibodies? I think.
Okay, sir. We will get it
You
done.
go for this, I think.
Okay, sir. Yes, sir.
Thank you so much, sir. I think now there is no question in chat box. So if you permit, then we can wind up, sir.
Yeah.
On the behalf of Dean ICP, Dr. Kamlesh Tiwari, sir, and our course director, Dr. Sudhir Mehta, sir, I thank you everybody who is present here and who have listened this beautiful talk by Dr. Sudhir Mehta himself, sir. Thank you so much, sir. And again, next week we'll have another talk on the hematology. So be there, and we'll have a last after the last session, we will have a online examination of 50 MC question will be there. I think 5 or something question from the each lecture, which we have learned since last 2.5 months. So everybody be prepared. Those who will take the more than 50% marks only will be provided the certificate. So just be ready for this exam also. And with the help of our President sir and Dean ICP sir, uh, at the time of Epicon, we are going to publish a book that is the preparatory examination, and this our section hematology will be in that book also. So you're requesting everybody to just come for the Epicon Bihar also. So we'll get that book also. Thank you so much, sir, for giving your valuable time, and thank you all the participants, residents, and
Sir,
everybody.
sir, I have one request, sir. Can we
Yes, sir.
know the date of the exam before so that we can adjust our duties?
Okay. Okay. I will just see how many lectures are there, and I think in next class we will declare the date for the exam also.
Thank you,
Sir,
sir. Thank you.
how can we get the PPTs of the lectures, sir, so that we can prepare?
So actually, this everything is being uploaded on the YouTube. So we'll give you the link. We'll give you the link so you can see all lectures on the YouTube. So once again, thank you so much, sir, and thank you, Mr.
Thank you,
Anand from
Zareen.
the Three Dots, for providing the platform. Thank you, sir.
Thank you. And
Thank
thanks
you, sir.
all, everybody for joining and giving great impetus to this course in hematology. Thank you all.